About another patient tonight, and again, it's interesting patient because this woman went through 18 different kinds of chemotherapy over years and years. She's a 72-year-old woman. She has fallopian tube cancer. Now, what the heck are the fallopian tubes? Anyone know? Well, the fallopian tubes are the tubes that connect the... Oh, I got a call from John. Well, we're going to take that in a few minutes. I want to talk about fallopian tubes. The fallopian tube is the tube that connects the ovary to the uterus. So every month, most every month, when the woman menstruates, before that period of time, the egg is ejected from the ovary and travels down the fallopian tube and ends up in the uterus, where perhaps it will meet some virile, fertile sperm and impregnate that egg, and it will become a little fetus and then a baby. So that's where the fallopian tube is. It's a connection between the ovary and the uterus. So this woman developed a cancer of the fallopian tube. And in fact, people can get cancers of most any part of the body. And me, after years and years, I've seen so much, I can tell you that almost every part of the body, from the belly button to, even there, I've seen cancer. So this woman developed fallopian tube cancer. She was diagnosed in 2005. At that time, she had bloating and shortness of breath, and she had an elevated cancer marker, which was CA-125, and some women get that for ovarian cancer. She was seen by a gynecologist who found a cancer stage 3 of the fallopian tube, and she underwent surgery at a big hospital and chemotherapy and radiation eventually. She had 18 different kinds of chemotherapy regimens over 8.5 years, including standard radiation at a very big hospital not so far from us. And she continued on more and more chemo and more chemo. And finally, she came to us because she was tired. You can imagine 18 different types of chemo over 8 years, and radiation and surgery, and nothing worked. Now, this woman is active and vital, and she wants to live, and she has a great life. And the point of her coming to us is to try to get off of the cycle of endless and seemingly useless chemo. She had radiation, which didn't work, and the surgery obviously didn't work because the cancer came back. It came back all in the pelvic area. She actually thought it was in 2 separate areas, but when we analyzed her and we sent her for staging, we like to do staging so we know exactly where the cancer is. When we sent her for staging, we saw that the cancer was in one mass in the pelvic area by the aorta and a major blood vessel going to her leg. So we're mapping out the treatment, and instead of 18 kinds of chemo over 8.5 years, we're planning on 5 treatments, each treatment about 15 minutes. She can come in, get her treatment, go to work. She had her first treatment. She had no side effects. She's doing well, and we anticipate the possibility of putting her into remission. There's no other cancer elsewhere in the body, so from our point of view, it's a pretty good case. From her point of view, she's hoping for the best. So are we. 5 treatments here, each one 15 minutes versus 8.5 years of chemo, weeks and weeks of daily radiation surgery versus 5 treatments with us. We wish her the best. She's working. She's doing great. So far, so good. And God bless her and her beautiful husband. And I want to talk about, just for a moment, skin cancers, because it's going to be the season with beautiful days like today that we're out in the sun. Well, we just saw a gentleman who's out in the sun every day. He's a seller of photographs on the street. You've probably seen photography out by the museums and other places. Well, there's people out a lot, and a lot of us are out a lot. And the more sun exposure we get, the more risk we have for skin cancers. This gentleman developed a squamous cancer. 2 years ago, he had it scraped off, but the roots of the cancer were left behind. It's right in the middle of the cheek, and He saw the cancer come back. He sees it every day. It's one of the most visible parts of the body, the face. We treat a lot of skin cancers around the eyes, nose, mouth, ears, cheeks, because when surgery is done, often it deforms those areas, and obviously the face is the most visible part of our body to our friends and associates and others. So he's choosing to proceed with us, which is a non-invasive technique for skin cancer. He has squamous cell, but we also treat basal cell, which is the other major one, and we also treat melanoma. Actually, melanoma, which responds poorly when it spreads to chemo or other treatments, responds very well to radiosurgery. So skin cancers, for those of you without skin cancers, think about a hat, think about sun protection, think about sun creams, frequent application, think about long sleeve shirts, think about putting on when you go to the grocery store, whenever you're getting sun exposure. If you're a parent, think about putting on your kids. Actually, most sun exposure occurs below the age or before the age of 18. So think about protecting your kids and yourself and your loved ones, and best of all, not getting skin cancer. Now, here's a gentleman who had a kind of tumor that he didn't do anything to get this cancer. Actually, not a cancer, benign tumor. This gentleman is very active, developed a pituitary tumor. Pituitary tumor is the master gland, so to speak. It controls many other glands, including the thyroid gland and sexual functions and menstrual cycle of women. So the pituitary gland is very important. It's located just adjacent to the optic chiasm, where all the vision comes. All the vision comes from the right eye and left eye and merges in the chiasm. So it's a very vulnerable and dangerous spot. When tumors grow in the pituitary area, they can take away our vision. In this man, he had surgery for the pituitary tumor. He saw an ophthalmologist, which is an eye surgeon, who referred him to a neurosurgeon. And he had surgery about 4 years ago for his pituitary tumor. He then had annual follow-up with MRIs. And the annual follow-ups, for all those years, they said, it's stable, everything's okay. But I don't think anyone called the radiologist to check or to compare the first MRI with the last MRI. Finally, shockingly, in January this year, he had an MRI which showed that the tumor had recurred. Well, you'd think it would be recurring because, again, the surgery removes part of it, but if it doesn't remove all of it, then the rest of it's just going to grow back. Well, there's a mass that was 1.44 centimeters. He came to us. He talked about all the options. His surgeon was pushing him to do more surgery. I said, well, you already did surgery. It didn't work. Usually surgery the first time is easier than the second time because the first time it's a pristine body. The second time there's surgical changes and adhesions and scarring. It's more difficult and complication rates are higher. And it didn't work. So he came to us, had treatment, just finished on Monday this week, 6 days ago. He finished his treatment. He went for an MRI on Friday. He asked me before I got the results, do you think it's going to be okay? I said, yes. He said, what do you think it's going to be? I said, it'll be about the same. Well, surprisingly, I got the radiologist on the phone so the patient could hear the results immediately. Didn't have to wait days and weeks and months and years. And in fact, his tumor shrank with focused beam radiation to the pituitary. It already has shrunken from 1.44 centimeters to 1.34 centimeters, and he only finished his treatment on Monday. And this was an MRI on Friday, 4 days later. So, yes, I am happy for him. The patient is happy. He's fully functional. He's a weightlifter, bodybuilder, trainer. He's got big muscles. He's in great shape. No side effects significant. He lost a little bit of hair, which will come back. No significant side effects. Fully functional, working, carrying on, and hope that he's going to be A-OK. So we wish him well, and his next test will be in 3 months to 6 months. We'll see him back and check on him on a regular basis. Do we have John still on the phone?
Good evening, Doctor. Good evening.
John, how are you?
Very good, Doctor. Excellent, excellent. Good hearing you this evening.
It's good to hear you always.
Yeah, Doc. What I wanted to hear, what I wanted to talk to you about was the fact that is there any difference in the tumor or the cancer in breast cancer and prostate cancer? Are they
there's a lot of, of course, I mean, there's the obvious, the organ that it starts with. One is in the breast, and usually it's the female breast, but men get breast cancer also. About 1% of breast cancers occur in men. There are many similarities. First of all, the number it's about 250,000 women getting breast cancer. It's about 250,000 men getting prostate cancer. They're both hormonally derived. So a few minutes ago, I talked about the pituitary being the master gland. Well, eunuchs, which are men without testicles, without testosterone, don't get prostate cancer. And women that don't have breasts or don't have breast stimulation generally don't get the same degree. Now, men get breast cancer. 1% of breast cancer occurs in male. So there's many similarities. The numbers, that they're both hormonally sensitive. We use hormonal agents. For example, in prostate cancer, there can be anti-hormones that are used. In women, there's anti-hormones like tamoxifen, Nolvadex, and others, Arimidex, that are used. So there are many, many similarities. There's screenings for both. Women can get self-examination, mammograms, ultrasounds, MRIs for screening. There's an increased family risk for both breast cancer and for prostate cancer. The BRCA gene, which is a gene that increases the incidence of cancer, actually increases breast cancer in women. It's most commonly thought about a gene, Angelina Jolie, who had her breasts removed because she had this BRCA gene and because her mother died when I think she was 47 years old, had her breasts removed. She didn't, accordingly to the journals, to the papers, didn't have her ovaries removed, but there's actually studies now if you have BRCA gene positive that you're going to decrease your risk of dying if you have your ovaries removed at a young age. And very commonly, they're removed after childbearing. I remember when a young woman, a 35-year-old woman, removes her ovaries, she's going to be going into menopause. And then the last point about it is actually there's an increase in men with prostate cancer who are part of the BRCA gene picture. So, yes, you're right. There are many, many, many similarities and overlaps between breast cancer and prostate cancer.
Thank you very much, Doctor.
All right, God bless you. And thank you. John, why don't you just, you're on the air, and I know that you like to talk about radiosurgery, and you're going through this treatment. So why don't you give the viewers just a capsule of what it's like to get treated and why you chose to get treated with us and what your view are. And you can be brutally honest. You don't have to sugarcoat it for me.
Thank you very much, Doctor. Well, about 6 months ago, I was diagnosed with cancer. I was urinating blood and wondering why, and my GP doctor sent me to urology, and urology said put me in a hospital for 10 days, did an analysis, a scraping, hooked me up with a bag, and I was diagnosed with cancer. I was sent to a doctor, a surgeon, and he said, John, you're between a rock and a hard place. He says, I'm going to have to take out the bladder, the prostate, and any of the organs in that area because I feel you're full with cancer, and I give you 5 years to live. Subsequently, I came home. I was really downhearted. I'm a 70-year-old man, and of course, you want to live life to the fullest. And a neighbor here, gave me a card, your card, Dr. Lederman, which was located in Manhattan, which is where I am. And subsequently, I went to see you, and you gave me some hope, and you gave me some light, and I prescribed to your treatment. And subsequently, I didn't have to go through that surgery. And the fact is that I was diagnosed for 20 years instead of 5 years. And I'm going through the surgery now, and it's very enlightening.
It's not really surgery. It's not really surgery. Can you describe what's actually happening to you? 'Cause it's not surgery.
No, well, it's not surgery. It's radiation surgery. Anyway, I'm
radiosurgery.
I'm going to 38th and Broadway. I'm going to Dr. Lederman's clinic. I usually walk there. Matter of fact, I try to get my exercise in the morning. I